Good morning. My name is Sonja Dieterich, and I'm the Chief of Clinical Physics at Stanford University Radiation Oncology. When I finished my training as a nuclear physicist and took my first step into a hospital, it was not back to the future. It was fast forward into the past, technologically speaking. At that time, you would order a computer and you could track it all the way from its Chinese factory to my office. On the other hand, it was still impossible and very difficult to track a patient's pathway through the different care providers and even transfer all the relevant information from one physician to the other. I, frankly, was shocked. After a while, you get used to things, but you notice more and more the amazing discrepancy between the level of care and dedication our physicians give to the patients and the very poor technical tools they have to put up with. We have 2 electronic medical record systems. Oh no, wait, 3 if we include Children's Hospital. And yet, despite this vast database of patient information, it is very hard to find pertinent information for patient care. And in addition, my department alone is employing 3 people to work full-time on creating yet another database that can be used for outcomes research. Starting a clinical trial takes an amazing amount of work. I had no idea when I stepped into this field. Just to study a very, very small subset of patients, it takes years of preparation, years of accrual, years of data analysis and publication. After this data comes out, a physician is required to read all these hundreds of trials that are conducted nationwide and even internationally, memorize the pertinent information, and be able to pull this out of their mind, out of their brains, whenever a patient with that particular situation shows up in their practice. That might work reasonably well at a large research hospital like Stanford, where physicians can specialize on, for example, treating breast cancer or prostate cancer. However, a community physician who has to cover any patient that comes in the door with any types of disease just in radiation oncology does clearly not have the bandwidth to do that. And because this information in the end ends up giving suboptimal care to the patient despite the best physician's effort, I got very frustrated and I started to think about what can be done differently. And there is where my hack comes in. I hope someone somewhere will read it, take the ideas, and carry it forward. Thank you.